Hello, everybody. Welcome to this kind of odd online lecture here. Sorry for the weird format, but to keep up with everything and make sure that we didn't lose any of our classes since we are right at the end of the semester, I kind of felt it was necessary to post this class lecture online. Hopefully you get just as much from this as you would in any in-person class, but if anything pops up, please do let me know. I understand that kind of following along in this particular format can be a bit challenging for students, even if they're kind of accustomed to online classes and treat all of their classes in kind of the same amount of effort and kind of vigor. So if anything pops up, please do let me know. But what I'd like to do today is just kind of keep up with our conversation that we were starting in our previous classes when we started introducing clinical psychology. But in this lecture, what we're going to do is kind of change our focus a little bit. So obviously, in the first couple classes about clinical psychology, what we were doing is really focusing on what clinical psychology was all about. We kind of get a sense of the different professions linked to clinical psychology, some of the difficulty associated with that particular profession. And then we started talking about things like the DSM and treatment options and different concerns that relates to not only people diagnosed with disorders, but people with also day-to-day struggles that maybe go see a clinical psychologist. What we're going to be doing in the remaining two classes, both in this one and the one that we'll have when we get back on Monday after Thanksgiving break, is focus in on specific disorders. Now, again, this does not mean that anybody going to see a clinician has to have some type of specific disorder. We're certainly not going to look at all of the disorders, even within these categories, let alone listed in the DSM. But what I thought doing this will allow us to do is kind of understand these ideas of clinical psychology and these concepts linked to mental health a little bit better and be a little bit more appreciative of some of the different problems that people encounter along their way and some of the common themes, common things that we see when talking about disorders in clinical psychology. And we're going to start in this class by focusing on the classification of disorders called anxiety disorders. And then we'll move into mood disorders right at the end. And in our class next Monday, we'll talk about other mood disorders and schizophrenia as well. Now, when looking at anxiety disorders, what we see is a group of or cluster of disorders that really have anxiety at its center. There's lots of other issues that can pop up. There's lots of differences from anxiety disorder to anxiety disorder, but at the heart of all of them is some type of anxiety linked problem. Now, we're going to, in this class, cover 4 different types of anxiety disorders, but it is important to note as we're going over these that there is actually one that we're going to be talking about at the end that is technically no longer an anxiety disorder. It's technically in part of the impulse control disorder category nowadays in the newest edition of DSM, something called obsessive compulsive disorder, or OCD. We'll get into why that's the case a little bit later, but I just wanted to kind of lay the groundwork so you could see what it was that we were going to be getting to in today's class. We're going to start when talking about these anxiety disorders by looking at one that probably most people feel is kind of the hallmark or the epitome of anxiety disorders. And it's just because when somebody hears the word anxiety disorders, it's what they tend to think about, something called generalized anxiety disorder. For the people struggling with this disorder who are diagnosed with it, what they often have is kind of this persistent, free-floating anxiety that's lasted for an extended period of time. Even the cutoff for this is a little light, it's about 6 months. Most people who report struggling with generalized anxiety disorder often report struggling with it for years, maybe even decades, depending upon the kind of extremity of their symptoms and whether or not they've tried to treat it or kind of what types of treatment they've actually pursued. For people who start with this disorder, what we often see is kind of initially this constant worry, this constant jitteriness that tends to result in the inability to sleep and the inability to really kind of function at the best of these individuals' abilities. Now, it's really kind of painful for individuals who struggle with this disorder is over time, because this often results in sleeplessness and distractibility and irritability, that it tends to eventually kind of evolve into not only somebody showing outward anxiety, but also outward exhaustion, and also kind of this lack of energy, lack of inertia because of all the different things that are going on. This particular disorder tends to be very comorbid with other types of disorders like depression and sleep disorders and other things that we'll kind of get to as we progress. In terms of who's diagnosed with this disorder, it's found in a decent percentage of the population. So about 6% of the population in the United States will be diagnosed with this at some point in their life. If we think about that in terms of our class, that means out of our class of 500, we're looking at roughly 30 to 40 people diagnosed with it. And the reason why I kind of go upward in the estimates is because there are some kind of breakdowns in the population that suggest that we might have a few more people in our class that are diagnosed with it than what we would expect to see in the normal population. One being that we tend to find people who are female to be diagnosed with this significantly more than males, and we obviously have a much higher percentage of females than males in the class. And the other two things actually don't quite relate to Berkeley students, but people who are described as being in lower incomes and having marital issues, or when they're in their interviews, they talk about those things, tend to be diagnosed with this more. Now, there's lots of questions as to why these breakdowns actually occur. Some have argued that this is actually just linked to groups that are more susceptible to generalized anxiety disorder. Others have argued that maybe this is more of a byproduct of biases that clinicians have in our current society, where if a female comes in and they're displaying problems, a clinician might automatically go right to generalized anxiety disorder, where they might not do the same for a male that comes in and seeks help. There could also be societal standards on what's appropriate to kind of display outwardly when you're experiencing lots of stress and lots of problems in your life. So there's a whole slew of potential reasons for why we see these imbalances across genders, but we have statistically seen them for an extended period of time. And when talking about disorders like generalized anxiety disorder, these are one of the things that we tend to mention just so people can have an understanding of where it's coming from and maybe some of the nuances to it that we need to tend to. Obviously, there's some other things that are really critical with this. So you're looking for specific symptoms. You're looking for stuff that's persisted for an extended period of time, usually. And for people who are struggling with this, usually intervention is really important. Now, intervention can come in a lot of different forms for generalized anxiety disorder. Historically, the thing that's been prescribed and worked really well is antidepressants, but there have been some very potent antidepressants that have been applied to individuals over the years, and they've had some kind of debatable side effects to them. So some of them creates really high levels of tolerance and withdrawal symptoms, much like many of the recreational drugs that you might have covered in your drug abuse section. Some of them don't really work effectively, but once people get on them, they feel like they need them, they psychologically need them. Uh, so there's a whole slew of issues that come around when it comes to antidepressants being prescribed for generalized anxiety disorder. But to be fair, there's a huge percentage of the population that report very high levels of efficacy with this specific type of treatment for generalized anxiety disorder. And if we're looking for newer trends in how this is treated, there's a lot of types of relaxation training that have been used and shown to be very effective. CBT approaches, cognitive behavioral therapy, have worked really well. And it is kind of an individualized thing as to what works best. But the nice thing with generalized anxiety disorder is there are some solutions that are out there. Finding them for the people that are struggling with this is sometimes a challenge. Even getting those who are struggling with this to go see a clinician to stay on top of things is a challenge for a lot of individuals. But if we're looking for a bright side to this, it is the fact that this is one of those disorders that tends to be one that can be treated with the right knowledge and the right plan in place. Now, another mood disorder that on the surface looks like generalized anxiety disorder, at least in its name, is panic disorder. But it's really important to note that even though these two sound very similar, the nuances to them are very different. The outcomes to them are very different, and kind of what the persistent problem in them is very different for these two types of disorders. When we're talking about panic disorder, we're not looking usually at people who struggle with persistent anxiety. Instead, what panic disorder is really highlighted by is persistent, what we call panic attacks that are occurring for these individuals on a semi-regular basis. Now, the DSM is constantly updating how many panic attacks somebody's required to have and for how long they're experiencing these panic attacks to qualify as being diagnosed with panic disorder. Because people can have panic attacks just out of the blue randomly once or twice in their life, or they can often have them in direct reaction to something. So if you say they're experiencing a lot of stress in your social life, or you've got a big test that came up that you didn't do too well on, that can trigger a panic attack. But for people diagnosed with panic disorder, these panic attacks are really coming out of nowhere. And when we're talking about panic attacks, we're not talking about the new kind of slang that people have where they're saying, I was really stressed about my exam, so I had a panic attack. We're talking about people who essentially have their what we call sympathetic nervous system go into overdrive. This is what we sometimes call our fight or flight system as well, where everything is functioning fairly fine, and all of a sudden, out of the blue, the brain triggers these cascades of reactions that causes the heart to beat faster, the eyes to dilate, usually sweating starts to be incurred, and this person suddenly starts to feel this terror almost in this situation. Now, there's other symptoms that do kind of vary from person to person about whether or not people feel like they're choking or going to pass out, or whether or not they feel like they have to run. But at the heart of panic disorder is always these panic attacks. And what really separates panic disorder from generalized anxiety disorder is most people struggling with this don't show outward expressions of anxiety on a moment to moment basis. It's just during these panic attacks where we really see that there's something linked to anxiety that they're struggling with, and kind of figuring out what's triggering the sympathetic nervous system to be activated when it really shouldn't be is the big challenge for clinicians working with this disorder. Now, fortunately, this one's a little bit less diagnosed than generalized anxiety disorder. It's only found in about 5% of the population. Unfortunately, there aren't a lot of specific things that clinicians can cling to when looking for who's going to develop this disorder. We know that genetics do play a factor in it. There's actually a considerable amount of new research that suggested that genetics might play even more of a role than we had originally thought in it. But if you're looking for specific subsets of the population or specific individuals who have a potential to actually be diagnosed with it, there's not a lot that you can grab at. So what you're looking for really is individuals who've started to experience a number of panic attacks to the point where it's really starting to impact their life, and these really are coming out of thin air. There's nothing in particular that's triggering them. Now, over time, this can evolve into another problem that we're going to talk about in the next slide when we talk about the issues with phobias. But on the surface, panic disorder starts as kind of its own unique thing where these panic attacks are happening on their own. Now, to treat panic disorder, there's been a lot of attempts and a lot of struggles to kind of try to tamper down this particular problem. Historically, antidepressants have been applied to individuals who had been diagnosed with panic disorder. It still is something that's used, and it can lessen the severity of the panic attack symptoms when these people are struggling with it. But there's a lot of debate as to whether or not it's really getting at the frequency of the panic attacks and even the source of the panic attacks that these people are experiencing. Same thing with behavioral therapy, where people will look for the cues that are indicating that a panic attack's about to happen and try to kind of curb it. Some researchers have actually suggested that it's actually counterproductive to go through this process, because what you might be doing is looking for cues that now trigger a panic attack versus cues that can help you minimize the effects of a panic attack. If we're looking for one silver lining with this disorder, it is that this one tends to come kind of in waves, where it's very prominent for a person for a short period in their life, and then it starts to dissipate over time. So the panic attacks become less robust and less frequent after they kind of get through the end of this big problem. But while people are really in the thick of it, this is a really unfortunate disorder to be struggling with, because it's really feels like for a lot of people it's coming out of the blue, and there's not much you can do about it to try to kind of overcome some of the things that are going on. There's hopes that some of these new attempts, clinical interventions, can really help individuals with it, but there's still a lot of debate as to what the best approach actually is for this specific disorder. As I mentioned when discussing panic disorder, this can sometimes lead to another disorder that's very comorbid actually with a lot of other types of disorders. It's something called phobias. Now, phobias are actually by far the most prominent anxiety disorder. It's found in about 9% of the population. Here we do see a gender difference again, where women are diagnosed about twice to four times, depending upon the studies you're looking at, is as much as males. And again, there's a ton of debate as to why this is the case. Is it just that the threshold is lower for clinicians to give females a diagnosis of it? Women are encouraged to kind of display behaviors that eventually lead them to developing these things, or just, there's just biases in kind of who goes and sees a therapist with these problems. But whatever the big reason is, We do see that women are diagnosed significantly more, and it's usually people who have some type of childhood issue, not necessarily abuse, but some type of thing that they've encountered that triggers this phobia that kind of eventually develops into a full-blown fear of something where these individuals really struggle to function as a result of these fears of something in particular that they've developed. Again, there's lots of misnomers about phobias that are out there. Some people say that, whatever you're scared of, you have a phobia of. We kind of use this term just randomly without really understanding exactly what it means and what the implications tied to it are. But in clinical psychology, to qualify as having a phobia, what you need is some fear of something in particular occupying a big percentage of your day and actually causing you to not be able to do certain things because of worries about this particular idea or concept. And again, phobias can come in a lot of different forms. So one of the more common ones is something called social phobia. It's also sometimes referred to as social anxiety disorder. Again, lots of misnomers out there about that one, where people who don't like talking to individuals say, well, I've got social anxiety disorder. That doesn't usually meet the clinical threshold for that. Usually people who are struggling with social phobia really cannot function when they get around individuals. They essentially break down in terror when they're forced to be around other individuals or have to kind of talk with people that they're unfamiliar with. This particular disorder, even though there's a high threshold for it, is found in about 4% of the population. And for these individuals, life is very difficult to kind of function with all the social interactions that we have in our current society. Another type of phobia that's very what we call comorbid with it, essentially the chances of being diagnosed with one increases your chances of being diagnosed with the other, is something called agoraphobia, where you have a fear of kind of open places, a fear of exposure. And agoraphobia is found in slightly higher uptick of the population, even social phobia, but there's a ton of overlap between those two. Another thing that's kind of often used in terminology when discussing phobias are these things called specific phobias. You can have fears of spiders, you can have fear of snakes, you can have fears of enclosed spaces. There's lots of different types of phobias that people have developed over the years. But in combination, when you add it up, you're looking at about 9% of the population being diagnosed with at least one or multiple phobias. And again, this tends to be very comorbid with a lot of other disorders as well. So when somebody's struggling with a phobia, maybe they're also struggling with depression or generalized anxiety disorder, or maybe it started as panic disorder and it eventually evolved into a phobia and panic disorder. So it does usually carry over to a lot of other types of problems. And lots of people do have multiple phobias that they're struggling with. As I mentioned, when looking for where this is coming from, we do know specific groups we're looking at. We also know that childhood issues tend to kind of be the mark of onsets of phobias. But it doesn't mean that you have to have some horrible thing happen to you to kind of develop a phobia. Usually it's sometimes a learning thing or some type of environmental thing. The book actually goes into a lot of detail about research looking at where phobias are coming from and some of the big precursors to developing it. But it's also probably important to note that when looking at phobias, we have found some genetic markers that are big kind of precursors to the development of phobias. And this has been kind of a hot topic of research, trying to figure out what those specific genes are, how they interact with the environment, and what's really critical for those things to eventually put people who maybe have a propensity for developing a phobia to that point where they actually do start to have their life really impacted by the stressors that they're encountering. In terms of treating this disorder, the one nice thing with it is that this one is pretty treatable. We saw in our video last week how behavioral treatment can work fairly well. Cognitive behavioral therapy can actually work pretty well for individuals. Medications can work to kind of lessen the extremity of the reactions. Usually people try to avoid medications alone when treating individuals and usually either use them in conjunction with therapy or just focus on therapy. But again, it's kind of a catered thing as to what treatment works best for individuals and trying to figure out kind of how people respond to the different things. But if we're looking for a silver lining to phobias, even though they're extremely common, they can really wreak havoc on a person's life when they're experiencing these phobias. They're pretty treatable for people who do actually go seek treatment. And that can be a big hurdle for a lot of people, unfortunately, is because these things are so scary for them, because it's really tough to try to kind of face this thing that's causing these breakdowns head on, usually people delay treatment for a long period of time, and it can eat away at their life until they actually go seek help. And when they do, usually they see pretty robust effects. And that's, I guess, the one good shining thing with phobia that we can latch onto if we're looking for, again, that silver lining with a disorder that's pretty common, but that really can eat away at people's lives while they're struggling with it. We're looking at one last anxiety disorder out there. Uh, with it, it's again no longer technically part of the anxiety disorders umbrella, but the book and I kind of like to keep it in this umbrella. Um, it's something called obsessive compulsive disorder. Now, the reason why obsessive compulsive disorder has been moved out of the anxiety disorders category and into the impulse control disorders category is because when you look at the outward symptoms of people with OCD, you see the impulses. You see these things called compulsions, where they're doing something on a regular basis. They're either checking things or cleaning things or doing some repetitive action. The compulsions can come in a variety of different forms, but the reason why it historically was linked to the anxiety disorders category was because of the obsessions that are kind of the precursors to the compulsions. Obsessions being that you need to do something or you need to check something or something bad's going to happen if you don't act in this specific manner. Just like phobias, these obsessions can come in lots of different forms. Right? There's lots of different categories of OCD that people will differentiate between if you get into this specific disorder a little bit more deeply. In terms of comparing it to the other disorders, I guess one of the nice things with this one is it doesn't happen that often for individuals. It's only found in about 1.6% of the population. But this one's been a real tough one to figure out where it's actually coming from. So we historically linked it to people described as hardworking perfectionists, people with slightly above average intelligence as well. But lately, a lot of research has kind of focused on genetic links to developing a specific disorder, and we have seen that there is a lot of heritability of this disorder for people who develop symptoms at a relatively young age, usually before about the age of 18. Once you get past 18, it becomes more of a crapshoot as to kind of who's going to develop symptoms and where it's coming from and what the heck was the trigger for a lot of individuals struggling with this disorder. But you know, this is still this kind of moving target that people are trying to tackle because when people struggle with this, it's not a desirable thing. It's something that's very frustrating for people because they know oftentimes that the obsessions are irrational and that the compulsions that they're doing really aren't fixing anything, but they can't get past this kind of belief in some catastrophe that might happen if they don't act on the obsessions that keep coming to mind. And that undesirability actually does separate obsessive compulsive disorder from another disorder that people often kind of accidentally mistake as obsessive compulsive disorder called obsessive compulsive personality disorder. This is actually a specific disorder that's more about perfection in every form, where you have to look perfect, you have to behave perfect, you have to do everything in this absolutely perfect way, and that can result in a lot of stress. But a lot of people who struggle with OCPD don't see it as undesirable as people with OCD. People with OCD don't like the obsessions. They don't want the obsessions, but they're there. OCPD people feel like there's usually some value in their obsessions, even though that's, I guess, not across the board for everybody struggling with this disorder. There are some that recognize that that can be really detrimental to them. Usually, there's a distinction there in that category. Another thing with OCPD is that that kind of need for perfection does carry over to pretty much every aspect of life, where OCD is usually fixating on one specific obsession that these people are struggling with and need some help with. And that, again, makes it slightly unique in comparison to OCD. There's other kind of qualifications that are really big for obsessive compulsive disorder that, again, distinguish it from what most people usually use the term for. So if you're somebody that likes to have your books organized or have really good notes for this class or just likes a clean room, you might have said to your friends, oh, I'm very OCD. Know that that's not really being very OCD. This is really more about having these things that you're kind of constantly obsessing about and you have to act on, where you feel just this tremendous amount of anxiety that starts to bubble up in you. In terms of how to treat this, There's some behavioral techniques that work really well. There's something called exposure therapy, where you kind of slowly or instantly, depending upon the treatment that you prefer, expose somebody to this thing that they're terrified of. And in doing so, usually over time, you can help them kind of recognize that their catastrophic fear was not actually legitimate, and that they can start to see their fears dissipate as they either don't get to act on their obsessions, or as they're kind of just not allowed to even think about their obsessions for a short period of time. The other thing that we see with this is that drugs can help, and also just time helps with this specific disorder. There's a lot of people that argue that maybe people are unintentionally occasionally doing their own exposure therapies when they're struggling with OCD, when just circumstances, life happens, and kind of prevents them from being able to act on some of the things that they're obsessing about. And through that, maybe they can find some type of help through it. So I guess if we're looking at the last anxiety disorder, even though again it's technically not an anxiety disorder, it's part of the compulsion control disorders. Um, it's one that is not as common, and it's one that's fairly treatable. It's just much like phobias, you got to get people in to seek therapy before you can really start to see the treatments working for these individuals. And that can be sometimes one of the biggest hurdles for a lot of people struggling with this particular disorder. And with OCD covered, that's going to kind of round out all of the anxiety disorders that we were going to talk about in class. Now, if you're wondering how in the world we got through all of this so fast, I was going to be showing you some videos to kind of highlight some of the symptoms that people report when struggling with these disorders. In the interest of time and trying to figure out how the heck to avoid copyright issues, I can't upload those things to the class site. But I promise you what we've covered here should give you sufficient information, especially if you're doing the readings in conjunction with this, on those anxiety disorders. And again, they're all listed as anxiety disorders, even though OCDs get different from it, because anxiety is at the heart of them, even though they all have their own differences in terms of how prevalent they are, the best ways to treat them, and kind of what makes them what they are and separates them out from some of the other stuff that we can link to anxiety disorders. The same idea is going to relate to the next group of disorders that we're going to talk about. And this group of disorders that we're going to be focusing on here is what we call mood disorders. Now, mood disorders is a very good name for them because essentially what people struggling with in this category of disorders is mood. And when we're talking about mood these people struggle with, usually it's the negative affects that they're experiencing, a preponderance of them, or really severe negative affects that can really be a detriment to these individuals' lives. It, it comes, if we're talking about mood disorders, in a variety of forms, and it's really important when we're talking about these that we acknowledge that feeling sad does not mean that you have a mood disorder. And if somebody's diagnosed as having a mood disorder, it doesn't mean that they're somehow off the deep end or somehow broken as a result of being diagnosed with this particular mood disorder, that they caught some bug. But what we're looking at here when talking about mood disorders is a variety of different problems that people struggle with that get past a threshold that qualifies them potentially being somebody that can really benefit from some type of intervention and some type of approach to kind of help them get themselves to a level that'll help them function better. And we're going to start when talking about mood disorders, actually only focus on when talking about mood disorders in this class, with the mood disorder that's most commonly diagnosed in the United States. In fact, the disorder itself that's most commonly diagnosed in the United States, and that's depression. And depression is getting pretty closely caught up with by substance abuse disorders. Maybe someday it will be taken over by substance abuse disorders, but what we see when looking at depression is the most commonly diagnosed disorder out there right now. And it's one that can pop up in a variety of different ways. Right? People diagnosed with depression are usually feeling some type of negative mood for a very persistent long period of time. Usually it's a couple months that they have to be displaying these negative affect symptoms. But when we're talking about the negative affect symptoms that people can display to be qualified as being diagnosed with depression, know that there's a lot of different things that clinicians can look for. The hallmark of depression is usually negative mood, lethargic behavior, where you're not really motivated to do very much stuff. But there's other things that can be indicators of depression as well. There's these feelings of guilt, feelings of worthlessness, the inability to pursue much stuff, sleep abnormalities where people just cannot possibly get a normal night's sleep. These things are indicators usually of depression-like symptoms. Now, these can also be tied to anxiety disorders. They can be tied to other things as well. So it's important to note that just seeing a couple of these symptoms usually does not qualify somebody as being diagnosed with depression. Usually you're looking for a number of these different things. But if you see a combination of things popping up in individuals, especially if those things are paired with negative affect, persistent negative affect, then you're usually looking at a diagnosis of depression. Now, there's another thing that's often tied to symptoms of depression. It's these things called suicidal ideations or even suicide attempts. Know that this is definitely something clinicians are attentive to when trying to talk with somebody that potentially could be diagnosed with depression or somebody who is diagnosed with depression. But there's a big misnomer out there that these two things go in hand in hand. So there's this notion that anybody who's depressed must be thinking about suicide, or that suicide is only discussed by people who have depression. I, this is definitely not the case. It's not necessarily common for people who aren't diagnosed with depression to be talking about suicide or thinking about suicide, but it's not completely unheard of. And there are a number of people that will have years of unfortunately, the diagnosis of depression that never get to the point where they think about suicide. And in fact, that is a big issue with many people in the psychological community, the therapy community, where they have people who are definitely displaying multiple symptoms linked to depression, but they feel like it's not worth going in to see somebody because, well, if they have thought of suicide, they couldn't possibly be diagnosed with depression. That misinformation is a big problem. It leaves a huge percentage of our population probably undiagnosed and untreated with something that they really should get help for. Because when you struggle with depression, this is something that can really eat away at your life. These things can really hurt your productivity, it can hurt your social life, it can just cause this major rift in a lot of different aspects of your life that isn't necessarily unnecessary, but it's undesirable. And the need to kind of assess what's going on and figure out a treatment plan is really critical for this specific type of disorder. If we're looking for who's diagnosed with it, again, gender comes up. I promise you, I'm not trying to bring this up constantly because of some bias. This is just raw statistics and looking for markers that are linked to things. You probably learned in your substance abuse class that males are significantly more likely to be diagnosed with substance abuse disorder than females. There's also other disorders that we don't talk about in this class, like anger-related disorders that males are more commonly diagnosed with. So it's not that it's always women that are more diagnosed than men with specific disorders, but for depression, again, females are diagnosed about 2 to 3 times as much as males, which means that since about 16 to 18% of the population is diagnosed with this disorder, depending upon the study that you're looking at and kind of what their estimates are based on, that means that about 1 in 4 women are diagnosed with depression at some point in their life, and roughly 1 in 10 men are diagnosed with depression at some point in their life as well. That's a really dramatic number, which means if we're thinking about it, a huge percentage of our class, a huge percentage of the people around us will either be diagnosed with depression at some point in their life, have some type of depression-like experience at some point in their life, or be very close to somebody who has been diagnosed with depression at some point in their life. So we can't necessarily think of this particular disorder as this bug that people get and it's indicated that they're broken, because it is all around us. And there's lots of things that can be the precursors to it. There's research that's focused on big life events that can change individuals' likelihood of developing it, genetics, childhood experiences, and the stressors that we encounter that could be maybe markers that kind of put people on the track to developing it. We do know that people diagnosed with depression, when we measure different types of neurotransmitters like serotonin in their brain, we typically see a typical production of those neurotransmitters in the brain, structures like the amygdala and other places. But what's causing it is still debatable. And it's probably important to note that because there's so many different symptoms linked to it, and there's so many different things that can be linked to kind of causing symptoms of depression, we probably never will find this magic bullet that's going to describe where everybody is developing depression symptoms from. But what clinicians try to do is try to understand as much as they can about where this is coming from, so they can also try to figure out what the best path to treatment is for people who do get to that threshold of being diagnosed with depression. If we're looking at treatment for depression, what we see is that even though this is something that can be very problematic for people struggling with it, there is a lot of hope associated with treating depression. Usually, for people with milder cases of depression, something as simple as sleep and exercise and kind of changing your eating habits can be a really good way to kind of stave off some of the milder symptoms that maybe don't require extensive psychotherapy or some type of medical intervention. And in fact, this is something that can be tied directly to college students, where there's been a lot of research that's shown that as you get into college and you start going to bed at, say, 2, 3 a.m. in the morning, like many of you I know you are doing, and you start eating nothing but pizza and hamburgers and other stuff every single night, and exercise kind of goes out the window for a while. There's a reason why upticks in depression are very common in college freshmen and sophomores. Um, Pair that with lots of stressors in your life that are usually occurring when you get into college, and you can see this upswell of diagnoses of depression that's very common. Well, not only can those things be linked to the causes of depressive like symptoms, but they can be kind of attended to in terms of trying to treat depression like symptoms. If you pair these things up with drug interventions, there's a ton of different types of drugs that can be applied as antidepressants. One of the classic ones is something called an SSRI, or selective serotonin reuptake inhibitor, which can actually kind of make serotonin more abundant in the brain, and in doing so, have a shift on the cognitions and maybe help somebody kind of course correct a little bit when it comes to their emotions and their thinking, to the point where maybe eventually they don't need those antidepressants to be able to function. Those things have proven to be fairly effective. Lots of psychotherapies have actually proven to be effective. In fact, almost all show about a 50% efficacy rate when just used on their own. And when you pair these up in conjunction with drug interventions, with regular sleep and exercise and diet changes, what we see with this disorder is it is afflicting a huge percentage of the population. And a large number of us will get past the threshold where we can be diagnosed with depression. Uh, and many of us will get right up to that threshold, and maybe we don't get diagnosed with it, but we'll get pretty darn close to it at some point in our life. And for those of us that are tinkering with that level or past that level, there are some treatments out there. And unfortunately, we have the ability to come back from some really nasty stuff when we are diagnosed with depression at some point in our lives. And this is good news. The rough news when it comes to depression is that this is one that maybe isn't lifelong, but it's one that you do have to attend to throughout your entire life. So the chances of being diagnosed with depression again at some point in your life are greatly enhanced once you've been diagnosed with it in the past. It's like your body is permanently sensitive to things that might throw you on the path of developing depression once you've gone through those first couple episodes. So being vigilant on symptoms, making sure that you're keeping yourself healthy is really critical to people, even once they've recovered from their bouts of depression, we'll call it, or the kind of symptoms that emerge once they start to go away. You have to be attentive to those things throughout life once you've been diagnosed with it, because this is something that is kind of persistent throughout the lifespan of a person once they've kind of gone through a depressive episode. Now, it's really important to note, again, that depression is not the only mood disorder that's out there. There's a lot of other ones that we can encounter. And in fact, in our next class, what we're going to be doing is focusing our attention on some other mood disorders that are out there, ones that have a lot of the similar characteristics to them as we saw in depression, but have nuances to them that really make them unique and put them in a totally different box when it comes to mood disorders that we see. After we cover those for a few minutes in our next class, we're going to turn our attention to the very last classification of disorders called schizophrenia, one that's significantly less common than all the other disorders that we've talked about thus far, but one that has so much information tied to it and so many stigmas tied to it that I felt like it's critical to cover it, just so we can be a little bit more sensitive to that specific topic and stop using terms like that's a crazy person or that's a person who's just messed up, because unfortunately in our society, that tendency is still very persistent. So in our next class, we will talk a little bit more about schizophrenia as well. But for now, we've gotten to everything that we were planning on getting to in today's lecture. So hopefully you got enough from this. I wish you all a happy Thanksgiving week, and I will see you all when we get back next Monday. Take care, everybody.